Hello, Rupa Health. I'm back to talk to you today about a conversation that a lot of people are talking about. If you're just meeting me for the first time, I'm Dr. LaKeischa, your international menopause whisperer, Oprah's own TV network expert in perimenopause and menopause, hormone specialist, speaker, and best-selling author of The Other PMS, Your Survival Guide for Perimenopause and Menopause. And like I said, today we're going to talk about a big topic that a lot of people are talking about, PCOS as metabolic syndrome's fraternal twin. You know, I always like to kind of tell you where we're going. So here is the outline. Talk a little bit about the history of the diagnostic criteria, what differential diagnosis you need to actually rule out and consider and make sure that you address those and make sure they are not part of the picture. Let's dive into the pathophysiology of PCOS. We're going to talk about PCOS and adolescence and PCOS and perimenopause and menopause. You know, I always love to give you some takeaways. What I would love for you to take away from this first part of the conversation is a paradigm shift. Think of PCOS as a subtype of metabolic syndrome. When you start looking at it through those lenses, I believe a lot of the planning and putting together a personalized plan you'll be able to do that in a more succinct way. Make sure you remember that PCOS doesn't have a set look. What do I mean by that? There are some PCOS patients, as we'll discover, that don't look a certain way. So you still have to have it as part of your differential, or you won't think about it being part of what's going on with that person sitting in front of you. And I want you to be able to help your PCOS patients understand that there's no silver bullet. There's no cure that we're holding back for PCOS. All right, let's dive on in. I know some people are like, how difficult is it to diagnose PCOS? I mean, you only need 3 criteria for the diagnosis, right? Let's talk about it. Well, let's look at the timeline for developing the diagnostic criteria for PCOS. In 1990, the NIH came up with a criteria. Then in 2003, the European Society for Human Reproductive Endocrinology and the American Society for Reproductive Medicine came up with guidelines. Then the Androgen Excess Society came up with a criteria. NIH came back into 2012 and said, hey, let's add on to what we talked about before, and they added on to the criteria. And then in 2018, the International PCOS Network had a diagnostic criteria where it kind of made a combination of some of the other previous criteria. So let's dive into it. NIH says, okay, you need to have plus or minus hyperandrogenism, which means there'll be some clinical features that you'll see, such as acne. You may see hirsutism, which is that hair growth pattern that's usually more so of a male hair growth pattern, or hyperandrogenemia, where you will do some blood test and find certain types of androgens in the bloodstream at an excess. You can have oligoovulation, or some people will say oligomenorrhea, and you need to exclude other differential diagnoses. That's what NIH came up with in 1990. So they were saying, okay, here are 2 diagnostic criteria that you need to have, and you need to make sure that you exclude other differential diagnosis. Then in 2003, the ESHRE and the ASRM came up with their criteria. They said, okay, you can have plus or minus oligoanovulation, plus or minus chemical or biochemical signs of hyperandrogenism, and you needed to have polycystic ovaries. Okay. So they're saying, here are those 3 criteria. A lot of people say, aren't there just 3 criteria? So they're saying, hey, you either see it as a symptom, the hyperandrogenism as a symptom, or you can see it in the bloodstream, that hyperandrogenemia, when you actually look at some of the androgens. And they were saying there needed to be an imaging component to this as well, which is that polycystic ovaries. Now, what are polycystic ovaries? Polycystic ovaries are where you can count 20 or more follicles in one or both ovaries, or when you do the measurements, the volume of the ovary is over 10 milliliters in volume. And so this is one of those things that we look for, that people were looking for. Is like, you've got to look for the polycystic ovaries. At first, this was considered to be pathognomonic, which meant everybody that had PCOS would have this particular diagnostic criteria. So the AES Society came out in 2006 and said, you know what? We're actually going to say that you need 4 criteria. You need the ovulatory and menstrual dysfunction. You need the hyperandrogenemia. You need the clinical symptoms of hyperandrogenism. And then you also need the polycystic ovaries. So now you have the AES Society that's saying we really want to see 4 of these criteria together before you can diagnose PCOS. Well, now the NIH came up and said we need to add another component to this. And this was that when they revisited some of their diagnostic criteria in 2012. And they said, let's answer this question. There's this overriding question that says, is there a genetic component to this? Is there a gene? Is there a gene that we can then say PCOS patients are actually getting passed down, and this is the PCOS gene? Well, when we looked into that question, there's not just one gene. There's about 19 different genetic loci that are associated with different components of PCOS. So there's not a one genetic loci that we can say this is the PCOS gene. But what is now talked about is that there is a transgenerational type of passage of different particular genetic combinations that can give you a phenotype. And so NIH said, hey, let's also add this phenotype criteria into the criteria, the Rotterdam criteria of diagnosing PCOS. And so the reason that they have this phenotype as part of the criteria now is because they notice that if you looked at the phenotype, those that had phenotype A, for instance, that hyperandrogenism, the ovulatory dysfunction, and the polycystic morphology, they tended to have more severe case of the different qualities that are in PCOS, or the different symptoms of PCOS, such as insulin resistance. They had a higher diabetes risk factor. They actually had more hyperandrogenemia, and they had more of the downstream complications from hyperandrogenemia, such as the lipid profile that was increased, cardiovascular dysfunction and disease, and CVAs and hypertension. So they said this is very important. Even though we cannot identify and say, yes, there is a gene, there is a transgenerational type of passage for when you look at women that have PCOS and their daughters and their granddaughters, and the risk of that coming and showing up, and the intensity or of how this can show up in a woman's life. Okay? Now, why is there so much confusion around this? Well, when I was looking at the research and I was diving into this particular statement came out, and it jumped out at me because it actually pertains to someone like myself, who actually graduated from training as an OBGYN way before 2018, way before the international guidelines were published. And so if you have people like myself that came out before then, we are relying on the Rotterdam criteria that says, oh, you need 2 of the 3, which is that hyperandrogenemia, that hyperandrogenism, or that anovulatory component, and or polycystic ovaries. The other thing that is interesting is that when you look at even OBGYN residents in training, they have identified significant deficiencies in the knowledge of the diagnostic criteria for PCOS. So know that PCOS does not have a particular look. There is that phenotype. You can have phenotypes A, B, C, or D. You do need to ask about a familial component so that you can have that as part of the whole conversation. And there are women that will present that will have the insulin resistance component, but will not exhibit the obesity that comes with that or the weight component that comes with that. You will have women that will have the anovulatory type of presentation or symptomology, but they may not have the polycystic morphology. So these are the things that you have to keep in mind. And this is why for some women and for so many women, I hear them saying it took a very long time for them to get their diagnosis, for them to understand what is going on with them physiologically so that they can feel back in control. So what are some of the other things, though, that we have to make sure that we rule out, that we have to make sure that is on the table and that we look at completely? Thyroid dysfunction. We know that if your thyroid is underactive, it can significantly impact if your cycle is regular or not. So there are, of course, a lot of people go get their blood drawn, their doctors look at it, and because they're in the reference range, you're fine. But remember, there is optimal, and we as functional medicine doctors, integrative doctors, know that there is a optimal. There are some people that even when they're in the reference range, they are not optimal. And so you need to talk to them about their symptoms. And if you look at them or talk to them, they have full-blown symptoms of underactive thyroid. So that needs to be addressed. Congenital adrenal hyperplasia. I remember hearing about that in medical school and talking about it and being told that a lot of times the presenting person that sees this will be the pediatrician, will be the person that pediatrician that sees the person when they're younger, because a lot of times this will present with other abnormalities at an earlier age. Cushing's syndrome, adrenal secreting tumors, 21-hydroxylase deficiency, non-classic adrenal hyperplasia. All of these can present with some of the same similar symptoms as PCOS, and their treatment modality is totally different. So these are the things that you really need to make sure are on the table in terms of making sure that you rule them out, because you want to make sure that if it is any of these, that you're giving the right treatment option. All right, let's dive into the pathophysiology of PCOS. Now, before we go into the pathophysiology, let's talk about some of the physiology that happens inside our bodies. We need to talk about insulin-sensitive tissues because a big component of PCOS pathophysiology is insulin resistance. So remember, there are tissues that are insulin sensitive, like the liver, skeletal muscle, heart, adipose tissue. And what happens is, think about it this way. When your patient or you get in a fuel source and you break it down and it goes down through the system, remember, and we're going to take a little trip back to another conversation that we had. In the intestines, as this comes down, it goes, this is a carbohydrate. This needs a chaperone because it's broken all the way down to a glucose molecule. It needs a chaperone. So then the incretins start being secreted from the intestines, right? And they send a signal to the liver, to the pancreas. They send a signal to the liver that says, hey, you don't need to make any more glucagon because we already have enough of the sugar floating around in the bloodstream. So don't dump out any more. And then it goes and it says, hey, pancreas, we need that insulin chaperone. So it starts secreting that. And you also have these GLP-1s that are secreted as well, right? And so these are the things that help to make this tissue insulin sensitive. This is why I say when you talk to your patients, you just ate a meal. It's that lunchtime. After you eat, get up and walk for about 10 minutes. There are studies showing that exercise snacking is amazing. And it is just as efficient as if you were to take a 30-minute time slot continuous and go and do some type of physical activity. But if you take exercise snacks 10 minutes throughout the day, and at the end of the week, you've had enough that add up to that 150 minutes a week that we need, it is just as effective as carving out that time, going outside, walking, or going to the gym, or going swimming, any of those. Because what happens is as you are moving, those skeletal muscles are saying, we need something to help make more fuel. So it looks at the insulin sugar complex and says, yes, come inside to this cell. I'm going to send you over to the mitochondria. We're going to make some wonderful ATP, and this is how we're going to use this up and not go store it over and store it as fat. The heart, now that you're walking, you are now asking your heart to increase its cardiac output. So it needs help. It needs that fuel that comes from glucose. The adipocytes or the adipocytes or the adipose tissue, however you want to name it. What happens is it actually starts, when it's insulin sensitive, it converts brown fat and it's able to help raise the temperature in the body. So the body temperature raises so that you can burn a kilocalorie and you can burn this fat as fuel. It goes over to the liver and help it do what it needs to do. So as you can see, knowing what tissues are insulin sensitive and what happens to them is the foundation so that we can talk about what happens when insulin resistance occurs. Now, ovarian tissue, it is very interesting because it is insulin sensitive, and it wasn't on that last slide, but it is insulin sensitive. And when it is insulin sensitive and it is operating in the right physiology, when the hypothalamus sends a message to the anterior pituitary, and the anterior pituitary then sends out that FSH, and it goes over to the ovarian tissue and it tells it, hey, we need you to make an egg. And so it starts recruiting a number of eggs, but remember, only one wins. And as it's recruiting, the ovary is actually secreting a little bit of estrogen, a little bit of testosterone, a little bit of progesterone, and it's sending a feedback loop up to the hypothalamus to say, hey, I heard you, so you don't have to keep stimulating, but for so much longer, okay? Now, when you have insulin resistance, that signal that comes from the anterior pituitary is not as sharp as it was before. So LH actually overstimulates the theca interna cells, which produce androgens. And when you produce these androgens then contribute to the hyperandrogenemia that is in the system. Hyperandrogenemia, then you have hyperandrogenism, which now you can have the acne, you can have facial hair growth. For some women, it actually causes hair thinning because the hair follicle has a little inflammation in it, and that testosterone could actually be converting to 5-DHT, which is not the best type of testosterone for the hair, and that can cause hair shedding. And so now that you have increase in androgens, you are also stimulating steroidogenesis, and we're going to see that on another slide. So when you have insulin resistance, it affects the ovary, and this is where you can see that polycystic morphology. Because remember, we're recruiting eggs, we're recruiting, but we never have that big ovulation, pull trigger, boom, one out. So that's why you can see this polycystic morphology. Does that make sense? That makes sense. But not everybody will have this polycystic morphology. Now, what can happen is that you can now have an inflammatory response that is now part of PCOS because of the insulin resistance, because of the hyperandrogenism, and we're going to see this tie in again. So because of the hyperglycemia, because now we have all this sugar and insulin floating around in the bloodstream because the tissues are not sensitive to it anymore, you have insulin resistance, you actually are now increasing a production of tumor necrosis factor alpha by the monocytes. I had a ophthalmologist give me this type of gave me a way to think of excess sugar and hyperglycemia. And this ophthalmologist is like triple board certified in diabetes, internal medicine, and ophthalmology. And his practice really does look at, and he treats diabetes and hypertension, and he's just amazing. He said, think of excess sugar floating around in the bloodstream as a lit match, and that lit match is bumping up against the sides of the arteries, the walls of the arteries. Boom, 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 boom. And when you have that trauma, what happens? The immune system kicks in to try and repair that. Well, you have this hyperglycemia that is occurring all the time now. And so now you have this production of tumor necrosis factor alpha by the monocytes. Now you have this low-grade inflammation that's occurring all the time. So you may see a slight increase in your white blood cell count. Your CRP definitely goes up. That's one of your inflammatory markers. Interleukin 6, interleukin 18 can go up. Macrophage inflammatory protein 1, monocyte chemoattractant factor, chemoattractant protein 1. The aldosterone-renin ratio is increased, which can lead to hypertension. And the adipose tissue now is releasing tumor necrosis factor alpha and interleukin 6. So now you have this little wheel that you're in now. Now you have this hyperglycemia, which is causing chronic inflammation, and now you see how things are brewing, right? The next thing is that hyperaldosterone, hyperandrogenism in PCOS. So remember, LH and insulin affect the axis. So when you have this insulin resistance, that LH is going to go up, and that signal feedback from the ovary gets dampened. It's not as sharp as it used to be because you're not necessarily increasing your estrogens and progesterone, you're increasing your androgens. And so remember, you can have this androgen steroidogenesis that occurs as well. You also increase CYP17A1. That particular enzyme is hyperactive. You're now reducing cortisol, which usually gives a feedback mechanism to the HPA axis as well. So now that feedback is disrupted, and you have an increase in the pituitary ACTH synthesis, which also stimulates adrenal steroidogenesis. So you see all this, just this little vicious cycle. So here is my representation of metabolic syndrome's fraternal twin. You have insulin resistance leading to hyperaldosteronism, which can give you elevated lipids, cardiovascular complications and CVAs and hypertension. You have this low-grade inflammation. You have adipose tissue dysfunction or hypertrophy, which is this vicious cycle all over again. Now, PCOS and adolescence. This is where I would employ you to have a continuous open conversation with your patients and their guardians, because this is one of the populations that gets overlooked, because when women first start their cycles, it can take about 2 years for their cycle to get into a rhythm, get into that 28, 30, 32-day cycle. And so when we talk about that anovulatory cycles, or we talk about that oligomenorrhea, that could be a regular representation of a teen young woman getting her body in a good cycle with the axis. But I tell you, if you look at your patients and they start exhibiting some of those signs of metabolic syndrome, if you start seeing insulin resistance that starts affecting their weight, if you then say to them, okay, you need to exercise more, and they're saying, I'm exercising, I'm eating clean, I'm doing all the things, and I don't know why I'm gaining weight, keep the conversation open. Say, you know what, there is a diagnosis that I'm going to continue to monitor you for. I just can't give you that diagnosis just yet. Okay, look at if they have hypertension. Look at and see if they have any of the symptoms of hirsutism, cystic acne. Look and see if they have other complaints of chronic inflammation. Look and see if there are some of these little subtle types of symptoms and signs that are coming through. And so what I say is have a continuous conversation. Continue to test their hemoglobin A1C. Continue to test their lipids. Continue to ask them about the changes in their cycles. Ask them about the characteristics of their cycle. Have them keep a journal. Do all these things so that they feel that they have a partner in this relationship. Ask about the familial history with the mother, the guardians, whoever is there available. Ask if there is a PCOS component in this family. And that way you can keep this conversation going. PCOS and perimenopause and menopause. So this is another population that it's pretty much not necessarily that you get a diagnosis of PCOS in perimenopause or menopause, because again, one of the hallmarks of perimenopause could be your cycles becoming irregular. So that could be a little difficult to be able to pinpoint, is this a PCOS picture or is it a perimenopause picture? So what we tend to do with our perimenopause and menopause patients is ask for a history. Ask how their cycles were. Ask them the questions about hirsutism, about acne. Ask them about things about insulin resistance. Ask them about their weight and has it always been an issue. Ask them if they have any symptoms of PMS, because I'm going to talk to you about another way to think of PCOS when we talk about the treatment of PCOS. So what happens in perimenopause and menopause, this is more so of a diagnosis, a retrospective diagnosis for these patients, because they are able to then give you a history. And if when you do their blood work, some of them, their testosterone levels are on the elevated side for perimenopause and menopause. And remember, that's one of the hallmarks, that's one of the criteria you can use, that hyperandrogenemia. And you can say to them, hey, at this particular time in your life, I would expect your testosterone to be on the lower side, but you actually have a high number or a high amount of testosterone, be it that free testosterone that's floating around that you go, maybe. And when we put all of this together, and so then you're able to help them have a bigger understanding of the physiology that is happening in their body. So let's talk about the treatment options. I love to be able to tell you where we're going. So for this lecture, we're going to talk about using Dutch tests, cycle mapping in the diagnosis and treatment, treat the metabolic syndrome in PCOS. You're going to address menstrual irregularity, and we're going to talk about using bioidentical progesterone. Yes, that's an option. What tests should you run for follow-up, and how do you make any adjustments in their treatment plan? Key takeaways, of course, that paradigm shift. I want you to think of PCOS as a subtype of metabolic syndrome or metabolic syndrome's fraternal twin. Another paradigm shift I just thought about that I would really like you to go back to, and that's incorporating progesterone. So think of PCOS as progesterone deficiency. Treat the parts of metabolic syndrome that are showing up in a patient's life, and help your patients understand that there's no silver bullet. There's no necessarily cure for PCOS. There's treatment plans to address the underlying biochemistry so that they can have a hold of it, so that the biochemistry doesn't overtake them in their lives. Let's get to work. All right, using the Dutch test and the one for cycle mapping in the diagnosis and treatment. So let's look at cycle mapping in the Dutch test. What this does is it looks at your estrogen and your progesterone during a certain time in your cycle. And this is really important when we talk about PCOSers, because it's going to tie into the menstrual irregularity as well. So here you see that we're looking at estrogen metabolites and progesterone metabolites during certain times in the cycle. What we're doing is looking at, this one looked at a 30-day cycle, and I hear all the time too, okay, doc, these patients have irregular cycles. How do you know where they are in their cycle? Like, that's just kind of paradoxical, right? Okay, this is where you can actually create a cycle for them. So again, tempering expectations. So you tell this patient it may take us about 2 months or so to get the data to be able to put together your plan. What you're going to do is, if a patient comes to you and says, hey, I don't have regular cycles, I haven't had a regular cycle in a while, how do I do this test? Because it tells me to collect at certain days, and I'm supposed to collect starting at a certain day until a certain day. You can actually look at the calendar and say, okay, we're going to create a cycle for you. So from calendar days 1 to 14, just because the math is easier, you're going to just count those days. On day 15 to day 28 of the calendar, or and just to make it easier, day 30, okay, of the calendar, or day 31, you're going to take your progesterone. And then you're going to stop on day 1 of the calendar, or day of the next month. You're going to count 14 days in, and then you're going to count to when you're supposed to do the cycle mapping for that time frame. Tell them to just collect as they're going, and just make sure that they're collecting on those days so we know what days they were. What you're trying to do is create a withdrawal bleed so that you have that 14 days, and then you can see what's going on in their luteal phase. So if you see here, the gray lines or the gray graphs are where the levels should be if they're having that type of an interval of a cycle. And here, this is for the estrogen, this is for the progesterone. So here's this patient's results. Her estrogen peaks like it should and starts dropping. Her progesterone never peaks, and her estrogen is kind of low as well. Now, you can take this information and say, oh, wow, okay, so we're seeing that you're rising and falling at certain times, or we can see that you're not rising and falling when you should. Again, if you use that paradigm shift and you think of PCOS in terms of progesterone deficiency, it can help guide you in terms of how you're going to create a treatment plan for patients. So in that luteal phase, when they should have a rise of their progesterone, they typically don't see that rise where it should, how high it should go. And remember, progesterone is estrogen's accountability partner. So one, it allows estrogen to influence the uterine lining, but not too much so that there's too much of a growth. And then it comes along, it stabilizes it until you're ready to shed the uterine lining. Okay. Other things that progesterone does for a patient is it gives them the ability to go to sleep, stay asleep, have that calming effect, be able to go and interact with neurotransmitters and be able to help with neurochemistry. And so those are some of the things that you're thinking of that can be helpful. Remember, progesterone can go and interact with your serotonin pathways, which can help with mood. So that's why some of your PCOS patients will show up as having depression symptoms or anxiety symptoms. So remember, if you think of it as a progesterone deficiency, then you can actually, it's easier for you to think about, oh yes, I'm going to incorporate this in terms of my treatment. So here's where we're going to get into looking at the Dutch Test Plus and being able to look at the adrenal side of things and the androgen side. So looking here, this is why I like having the cycle mapping as part of the Dutch test testing as well, because you're able to look at the androgens. And remember when we talked about actually the diagnostic criteria was to look at hyperandrogenemia or androgenism, so you can see it as a clinical sign or symptom, or you can get and see it as a biochemical marker. When you do that in serum, and we're going to look at that, you're looking to see certain markers that are in the serum. Here with the Dutch test, it's helping us to look at the metabolites as well, as well as some of the as well as the enzymatic activity, right? So here we have 5-alpha reductase activity. We know 5-alpha reductase activity can tend to lead a person to metabolize down an androgenic pathway, a higher androgenic pathway. And that is what is happening, is what you can see here. So these androgens tend to be more androgenic, which means to stimulate or cause or show up those androgenic clinical signs and symptoms. And I keep doing this because a lot of times it's the hair here on the chin or above the lip. You have some women that have hairy arms, hairy legs. They have a pattern that goes into the thigh area, or they'll have hair coming up their stomach. So these are things that you can see. And then if you have the biochemical markers, that can be another piece of data that can help you with your diagnosis and treatment. Because we're going to talk about this. We're going to talk about how we can address the 5-alpha reductase activity. Now, the next one that I like to look at here is the adrenals, because we know that when you have more androgenic activity and you can stimulate the sterogenesis pathways that are in the adrenals, you can then also affect the cortisol and cortisone pathways that come from the adrenals too. So you can see where a patient can have lower cortisol metabolism or metabolites, and this can interfere with their energy levels, right? We see here that the adrenals, when cortisol goes down and you have low cortisol metabolites, it can affect that person's ability and affect their metabolism. Okay, so not only do they have metabolic syndrome type of characteristics or parts of metabolic syndrome that are showing up, but their metabolism is being affected. And I think we talked about that in part 1. Metabolism is the body's ability to raise the temperature 1 degree so that you can burn a kilocalorie. Right? And how long does it take that? So for some people, it takes longer for that to happen. And that's why you can have this slower metabolism. Other things that we can look at through Dutch testing are your nutritional organic acids. These are components, I call them cofactors, that are necessary to help those reactions to be as efficient as they can be. So we can look at metabolites that come from B12, B6, biotin. You can look at glutathione, which is a great antioxidant in the body to help decrease inflammation. You can also get a peek into their gut health through this particular testing, but we're going to talk more about that in a minute. So this particular testing, I love it because it's a little more comprehensive. It gives you more data points so that you can have a more well-rounded conversation with your PCOS patient. Okay, so this is one of the things that you can do, is using the Dutch test cycle mapping in terms of diagnosis and treatment. And we're going to talk about treatment because when you treat certain aspects of metabolic syndrome, you're going to be able to see the resultant effect when you do your follow-up. Treat the underlying physiology of metabolic syndrome. So this is what I'm super excited about in this part of the conversation, treating the various different components of metabolic syndrome. So let's talk about treating insulin resistance. You can use metformin to treat insulin resistance. Metformin has been shown in studies to be able to make the cells more insulin sensitive. Remember back in part 1, we talked about insulin sensitive tissues. So what does this do? What we want to do is allow tissues to be able to recognize that insulin sugar complex, that it needs it to come inside the cell through the insulin receptor to be able to do the work that it needs to do in order to get to the mitochondria, in order to produce ATP, which is energy, to help with metabolism, to help this whole body do what it needs to do, give it energy to work, okay? So metformin, usually 500 milligrams. Some people need to go up to 1,000 milligrams, even 1,500. One of the things that happens with metformin, though, for some people, they do experience the GI side effects or the discomfort. So they can experience diarrhea, cramping, nausea, even when they take it with food. And so they are not able to particularly probably break down some of the other fillers that are in the metformin to be able to utilize it to its fullest. So what do? Well, there is a molecule that I believe is wonderful, and it is the punitive treatment for PCOS. That's one of the research papers that I found said that. And it's inositol. There are about 9 different isomers of inositol, but 2 in particular that we look at when it comes to treating insulin resistance with PCOS is myo-inositol and dikiro-inositol. What these 2 different isomers do is that they work together, and they can work together in a synchronizing type of fashion. And so that's why I like to use them both. Myo-inositol tends to affect your hyperandrogenism. It tends to affect your high cholesterol. It tends to help that insulin resistance, some of those insulin resistant components. In the ovary, myo-inositol tends to convert to dikiro-inositol as well, which can help with the insulin receptors in the ovary become more sensitive. Myo-inositol helps the tissues to be able to utilize insulin and sugar more efficiently. The dosage for myo-inositol can be up to 1,500 milligrams is what they actually studied when I looked at the papers that I was researching out this particular component. Now, what dikiro-inositol did is that this particular isomer was brought into the conversation because remember we talked about familial transmission or transgenerational transmission of PCOS. We did not label it a genetic type of transmission per se, but this is why you bring in the phenotypes for PCOS. The phenotype A and B particularly had more of incidence of insulin resistance, the hyperandrogenism, and so these particular phenotypes it was also noted that their insulin receptors were not as sensitive, and dikiro helps those insulin receptors to be more sensitive in those type of patients. So that is why a lot of formulations like to combine myo-inositol and dikiro-inositol together, because we're not testing to see, are we going down and seeing can we test for the insulin receptor activity, right? So it's kind of like hedging your bets. And when you add both of those, you not only help with the ovarian function, you help with the insulin receptor, and dikiro helps excess glucose in the bloodstream to get excreted by the kidney. So you're helping to regulate blood sugar regulation that way as well. So you have this kind of dual component. You have this 1-2 punch when you look at the inositol and dikiro and myo in particular. Exercise is another thing that helps make tissues more insulin sensitive and helps to decrease that insulin resistance. When you get up and move, okay, so I tell patients, if you can do exercise snacking throughout the day, that's just 10 minutes of walking, maybe walking the floor plan of your office, your home, wherever you are, after either in the morning or especially after you eat your lunch, being able to use that fuel you just put inside and say, yes, I want to use it over here as fuel. So when you're walking and moving the big muscles, the biceps, the quadriceps, the hamstrings, when you're moving these muscles, they become more insulin sensitive. So exercise can be very helpful. And I'm not talking about making your patients do these high intensity workouts, and we know that that actually stresses out the adrenals more. Having them do strength exercise as well can be helpful because you're building muscle. Muscle is more metabolically active at rest even, okay? So building that muscle. Exercise can also influence the fat to turn into brown fat. And brown fat, as we're going to find out later, is more metabolically active at rest, okay? So these are all, see how you're affecting all different components of PCOS. The next thing we need to treat, the next symptom of metabolic syndrome, is the hyperandrogenism. This is where we're going to go back and look at that activity of the 5-alpha reductase activity. When you are favoring the 5-alpha pathway, you are making more androgenic hormones. And it can result as having that hyperandrogenism, okay, clinically. You can have more hair here, more hair here, more hair here, more hair on the thigh area, up the stomach area. And so you can actually have you can actually affect that activity. Some people will utilize, and also when you have hyperandrogenism, you can actually increase acne activity. And that tends to be that cystic acne. It can, even when you have high levels of 5-alpha reductase activity, affect the hair. And when you have those high levels in the hair follicle, it does not make the hair as strong. It loses its strength, so it tends to fall out. So these people will talk about possibly thinning hair. So they'll have thinning hair up here, but then they're like, my hair is migrating. It's going in places I don't want it to go, right? Okay, so you can use spironolactone to affect the acne component of it, and that will help to decrease acne outbreaks. You can use finasteride to work with the hair component of it, or you can use stinging nettle or saw palmetto. Those tend to help slow down the activity of the 5-alpha reductase and help it favor the beta pathway versus the alpha pathway. All right? So this is you can actually look at how you're influencing this by repeating that Dutch test so that you can see the activity of that enzyme. I'm not measuring the androgens, I'm affecting the activity of that enzyme. Does that make sense? Okay. The other things that you need to remember, hyperandrogenism can lead to elevated lipids, cardiovascular complications, and hypertension. This is where I say, okay, there are some people that will talk about using statins. When I look at a PCOS patient, they're making more triglycerides, more LDL. You can use red yeast rice. Red yeast rice can actually act as a resin. It acts as a nice little sticky piece of glue that will pull the cholesterol out into a patient's poop, basically. Now, when you use red yeast rice, because when you have a patient using red yeast rice, make sure you are supplementing their CoQ10 because it utilizes CoQ10 just like a statin does. So if you have them on red yeast rice, make sure that they're on CoQ10 as well, all right? The other thing that can be helpful in lowering their cholesterol levels is fiber. Adding more fiber to their diet, more whole foods. Because when you take in the whole food, you're stabilizing blood sugar, and you're creating that fiber, which will help to pull out that cholesterol in the patient's, basically their poop again. Remember, that's what we're talking about. Now, when it comes to the hypertension component of it, make sure that you have a patient understand the significance that hypertension can have on their vascular system. When you have a high pressure going against the blood vessel walls, you can create micro trauma in the walls of the vessel. A way that the body comes and makes sure that it repairs those micro traumas is through cholesterol, making sure it patches up those little micro tears with cholesterol. When you have unregulated high blood pressure, you can have these micro tears happening in the kidneys, happening in other small vessels, happening in the eyes. You can have these micro tears happening in the brain. And so this is where you have this sequelae where you can have kidney issues with hypertension. You can have eye issues with hypertension. You can have complications leading from complications from strokes. So you want to make sure that they understand. If if their blood pressure is at a point where it is significant, it needs to be managed acutely, help them understand that taking medication, taking a prescription medication for hypertension can really help to make sure that they do not have complications from high blood pressure, the ones we talked about, that can lead to organ failure, strokes, heart attacks. If their blood pressure comes to a point, and the other point I want to make is, because we know that PCOS hypertension is usually from that angiorenin system, you may want to utilize a blood pressure medication that's in that class, so that you can affect the adrenals and affect that particular system as to bring down their blood pressure pretty significantly, and making sure that it stays controlled. The other thing I would help that patient understand is that the angiorenin system, part of the adrenals, this is part of that sympathetic nervous system, where you need to balance out the sympathetic and parasympathetic nervous systems. You need to learn how to bring the parasympathetic nervous system back on board. That is where you do your meditation, your breath work. You also can, make sure that you're doing something that literally takes the sympathetic nervous system offline and says, you're not being chased by the saber-toothed tiger. Everything is okay. And they're able to relax their shoulders. So this is part of treating the hyperandrogenism, is treating these other components that can crop up. Remember, the hypertension can come from the adrenals. Remember, we need to treat the adrenals. You need to also look at their cortisol levels, making sure that they're making enough cortisol overnight to be able to have the restoration so that they can make it through their day. So these are the components that you need to have in your head, that you're thinking of as you're going through, what am I treating? What component of metabolic syndrome am I treating? Okay, now we're going to talk about low-grade inflammation, and this allows me to talk about one of my other favorite subjects and bring all of this back together. We're going to talk about the gut. A lot of our inflammation is in the gut, and we need to address this. And this component of metabolic syndrome, this component in PCOSers, is huge. It is really significant. So remember, hyperandrogenism can lead to chronic low-grade inflammation because you're actually stimulating and having a stimulation of your immune system. And it's at a low grade, but you're having this chronic stimulation of the immune system. Remember, the immune system can be found, a majority of it is found in our gut. And if we don't have the proper balance of bacteria, and you have this low-grade inflammation going on, you have this dysbiosis that happens. And when you have this dysbiosis that happens, when you have this imbalance in the microbiome, you're not able to metabolize your hormones properly. You're not able to set up the environment that helps you metabolize these hormones properly. And so now you're kind of in this vicious cycle. Now, this particular GI map, this is just one that I like to use by Diagnostic Solutions, and this is not a PCOSer, but what I want to show you is this component right here. So when I'm looking at the commensals, particularly the commensals, I'm looking to see about acromencia. We know that acromencia's population in the gut is significantly tied to blood sugar regulation and increasing risk for obesity and diabetes if it is not in the area that it should be, if it does not have the population that it should. So that's why I look for acromencia. I also look to see about these two in the bacteria phyla of Bacteroides and Firmicutes. Want to make sure that their ratio is in a good ratio. So I'm not only looking at the ratio, but I'm actually looking at the population, because we know that when you have the right amount of Bacteroides to Firmicutes, you do have an influence over your estrogen metabolism. You have an influence of utilizing your fiber properly that's in the diet, or if you need to use a fiber supplement, when the bacteria is there to eat up the fiber, it makes butyric acid or butyrate, right? Which is a small chain fatty acid, which helps with blood sugar regulation. You see how all of this is connecting, how it's all tying up together? So making sure that you do this can be very helpful in making sure that your PCOS patient has the right bacteria makeup. The other thing I look at is to see about their beta-glucuronidase. Remember, beta-glucuronidase can come in and snip the nice little packaging of the estrogen, open it back up, and so it's swept back into the bloodstream, which can contribute to estrogen dominance symptoms, right? The other thing I'm looking at is to see, is there any inflammatory markers? Is there any inflammation that is happening there? I'm also looking to look at and see if the digestive enzymes are there in the right percentages or in the right amounts, so that we can make sure that the stomach acid is there to digest properly, to make sure that certain bacteria don't get down into the large intestines that should only be staying in the small intestines, so that we're not having to worry about SIBO, right? So making sure that the gut health is there is paramount. It is paramount. So not only are we helping with the insulin resistance by giving certain supplements or medications to help with that, utilizing lifestyle, we're also making sure that there is bacteria that is there that can make sure that it metabolizes what's brought down in the gut to be able to contribute to insulin sensitivity. Okay? The next thing we're going to talk about is that adipose tissue. That dysfunction of the adipose tissue, the hypertrophy of it. So how do we affect the adipose tissue? This is where we're going to go back to that conversation of the GLPs. So you ingest that fuel source, whatever it is, it gets broken down. There is a signal in the intestines through the intestinal lining, those nice little cells that start secreting incretins. Remember that? And these incretins then send signals to the pancreas and to the liver. The liver, it says, hey, you don't need to make any more glucagon. We got it. We have a source of fuel out here that we're going to use. It then sends a signal to the pancreas and says, hey, we need you to send out our chaperone insulin so that we can go to these insulin sensitive tissues and be utilized. And then what happens is there's this feedback loop. It goes to the brown fat, and the fat actually becomes brown fat so that it can actually metabolize. So we can increase the metabolism. Okay, so as we increase the metabolism, we're making brown fat, you're actually burning and utilizing, and there is this nice feedback loop that goes into making sure blood sugar is regulated. Now, we talked about GLPs, we talked about GLP-1s, we've talked about how there are GLP-1 agonists that are out there that are doing the same thing. We also talked about a natural alternative, which is berberine. Berberine can go and do the same thing. Berberine also has a nice little added benefit. It can go back to the gut and it can help with that gut microbiome. It can help make sure that you're making the right forms of the microbes to be able to metabolize so that we can continue to have insulin sensitive tissues. We can continue to have blood sugar regulation. Do you see how this is all pulling together? I love it. All right, let's talk about the next thing we need to address, which is menstrual irregularities, because this is one of the biggest interrupters of life. This is one of the biggest symptoms that can interfere with a woman being able to live her life. And as a woman who has dealt with menorrhagia for a different reason, it can be embarrassing. You can feel helpless, and you then feel drained because you are literally losing blood. Okay, so your iron stores have gone down, your hemoglobin and hematocrit have gone down, your oxygen carrying capacity has gone down. You see where I'm going with this? It's this domino effect. So dealing with menstrual irregularities is paramount. It is paramount. So here's the discussion I have with patients. You need to ask them about their contraceptive wants and needs. If they are at a point in their life where they really need contraception and they're having menstrual irregularities, you can tell them about the options that are available through synthetic progestins. So there is Depo-Provera, there's Progestins only type of oral contraceptive or combination oral contraceptive pills. There is a progestin type of an IUD. So I tell patients it's either daily, probably quarterly, set it and forget it, okay? So the Depo-Provera is quarterly because it's once every 3 months. Now, the conversations around Depo-Provera include having to tell a patient that they will have menstrual irregularities possibly for 2 shots, which means 6 months, while their body is getting adjusted, while this Depo-Provera is getting deposited into the fat cells and then released as it needs to. It can cause irregular bleeding. So it can actually make things look worse or feel worse before they get better. The other part of the conversation when it comes to Depo-Provera is that you have to talk about the length of time you're going to use this consecutively. Because studies have come out showing that if you use Depo-Provera for 2 years, longer than 2 years, you increase a patient's risk of developing osteopenia and osteoporosis. I just make sure I give the patient all of that information so that they are fully aware of what can happen after they get this Depo-Provera shot. Once their body gets stabilized to it, because it's a progestin, they can, and it acts on progesterone receptors, it can actually influence how, it can actually downregulate estrogen receptors so that there's really no growth of the endometrial lining, okay? The same thing can happen with oral contraceptive pills and with the IUD. So what can happen is over time with these components, with these progestins, you can actually stop seeing a cycle. So that can potentially help someone feel as if they're in the driver's seat. Now, oral contraceptive pills, I tell them you have to take this the same time every day because you want to create a bioavailability that is consistent, because you don't want to have your levels go up and then drop and then up and then drop, because that will lead to irregular bleeding and spotting. The Mirena, or I think is Skyla, is the other form of an IUD that has levonorgestrel in it. It is a reservoir of progestin that seeps out, or that gets released over 5 years, 3 years, whichever one you're going to use. Now, when it comes to an IUD, you can have irregular spotting and bleeding for about the first month or two while the IUD is getting seated. That's what we call it. So you can tell your patients while the IUD is trying to figure out how it wants to sit in the uterus, that may cause irritation in the lining, which will cause you to have this irregular spotting and bleeding. So these are forms of contraception that can also help regulate a cycle. You need to help them understand it is a synthetic hormone. It is progestin. So which means it can act on the progesterone receptors. It acts like a key that can turn on the progesterone receptors. You can use bioidentical progesterone if the patient is not in a position to have contraception. If they're saying contraception is not part of my plan right now, you can use bioidentical progesterone, and this is the difference. So if you look here, you have human progesterone, and you look at the structure of bioidentical progesterone. They look the same, which means the body takes it in and says, I know what to do with this. I break this down like this, and I ship off everything to the proper place and get the waste out that we don't need, get it out of the body efficiently. When you have a synthetic progesterone or a progestin, like is what's seen over here, it can stimulate progesterone receptors. So it acts like the right key and it stimulates, but the body breaks it down into other types of metabolites that can be circulating in the system. And if your body takes a long time to actually get it out of the system, that's when you can have other types of side effects. Okay, so progesterone can come in several forms. It can come in the form of the contraception that we talked about, which is an injection, a pill, and an IUD. It can also come oral progesterone. This is bioidentical, can come in a form of a capsule. It can come in the form of a suppository, or it can come in the form of a transdermal progesterone cream. Oral progesterone, unlike the oral contraceptive progestin, should be taken at night because the oral bioidentical progesterone should make you drowsy. It should help with that cascade of events that happens in your neurochemistry that helps you to start that whole cascade of falling asleep and staying asleep. Progesterone suppositories are mainly used in patients when it comes to fertility conversations. They're utilizing a suppository that can affect have a localized effect on the uterine cavity. So I tend to use oral progesterone or transdermal progesterone cream when I am not dealing with a person that we're having a discussion around fertility, acutely having a fertility discussion. And when it comes to progesterone creams, you may have to apply it multiple times throughout the day in order to get that bioavailability to the level that you actually feel it. Okay? And so how do you prescribe it, right? So this is where you can do a luteal phase. You can cycle it. So the oral progesterone and the transdermal progesterone, you can cycle it and have a patient use it in what would be their luteal phase. So this is where you may have to you'll have to tell a patient, we're about to create your cycle. We're about to get it onto a schedule. So this is where you can use a calendar and say, okay, days 1 to 14 of the calendar, don't use your progesterone. Days 15 to 30, use your progesterone. And I just use that because it's just easier with numbers and it's easier for compliance, okay? So 15 to 30 or 31, that month, a month that has 31 days, go ahead and use that 1 day extra of progesterone. It's okay. All right. And that's where I say, okay, when you come off your progesterone is when you should have a bleed. Okay. It may not happen the very next day. It may happen a couple days in between, but just count the calendar days. That way you stay on a schedule and it's easier for compliance sake. Now, what tests should you run to follow up on the plan that you've now put into place? So either you are attacking your insulin resistance, you are looking at your hyperandrogenism, you're looking at your chronic low-grade inflammation, you're looking at your adipose tissue, or you're looking at menstrual irregularities. Whatever you're doing, how should you follow up? So whatever area of that metabolic syndrome that you are affecting, this is how you should follow up. You can follow up with serum testing, you can follow up with urine testing or saliva testing. But know what you're doing with each modality. So with serum testing, you can actually look at where they are in their cycle and do a serum testing to see if you're getting the levels in the bloodstream that you would like that are matching up to their symptoms resolving or their symptoms feeling better. A lot of PCOS patients, when you put them on progesterone, actually start getting better sleep, because remember in the progesterone lecture, progesterone breaks down into neurosteroids, which go and interact with the neurochemistry, with neurotransmitters. It can help with the serotonergic pathway. It can help breaking down serotonin into melatonin and melatonin into that cortisol. So it can affect their cortisol levels overnight. You see how this is all pulled together and working together? So if you want to, you can look at the serum levels at a certain time in the cycle you have created, or they are now creating, to make sure that the dose that you've given them is working and is matching with the symptomology relief. Okay? Because I have a lot of PCOS patients that come to me that have insomnia. They have insomnia at certain times when their progesterone, the little progesterone they may have, or if their progesterone was at a good level and then it dropped. And so now they're having insomnia. And when they are on the progesterone during that luteal phase of their cycle, they're like, oh my gosh, I'm sleeping so much better. I don't feel so anxious anymore. So these are the things that you can follow up, that you can actually put in and say, that's helpful. It's improving. These are things that are helping. You can do the urine testing. Look at that Dutch test again. And you can look at their 5-alpha reductase activity if that is one of the things that you have to look at. If you're looking at some of the components of hyperandrogenism and you're looking at some of the biochemistry of it, that serum testing can look at 5-DHT, or the urine testing can even look at that metabolite on the Dutch test. You can look and see if there are cofactors, those nutritional organic acids, if you've made some adjustments there, if those numbers have changed. There's so much that you can do in the follow-up to make sure that what you've put into place is actually beneficial. Saliva testing can be beneficial if you're looking at how their hormones are during certain times of the day, because we know that saliva testing looks at the bioavailable free component of that particular hormone at certain times of the day. Okay, so that's important to note. So know what your testing modality is telling you, know what it is showing you, so that you can take that data and you can apply it the correct way in order to be able to help your patient, and you know what is the next step. So this links to the next question. How do you adjust the dosing? You adjust the dosing according to the data that you have, and by simply remember to ask the patient how they're feeling. If you have if things are coinciding, if it's adding up, if they're getting better, if they're feeling better, then all you have to do is kind of say, okay, let's tweak this. Let's tweak the next thing. Some people like to start slow. They don't like to do too many things at once, which is fine. So, hey, let's work on the insulin resistance. Well, how do you look at that? You can look at fasting insulin levels. You can look at, that's the serum testing. You can look at hemoglobin A1C levels. That is an indicator as well. So there are various different modalities, there are various different testing that you can look at to be able to look at what you're actually attacking or what you're actually working on. If you're looking at hyperandrogenism, if you've had to attack the lipids, if you've had to look at the blood pressure, these are various different indicators that you can look at various different indicators to look to see how you're doing on various different components of the metabolic syndrome. We've done it. We've come to this part of the lecture where I want to make sure that you are mindful and remember the key takeaways. Have a paradigm shift and think of PCOS as a subtype of metabolic syndrome. The other paradigm shift that I'd like for you to have, think of PCOS as progesterone deficiency. Treat the parts of metabolic syndrome that are showing up in your patient, that are affecting your patient's ability to function. And remember to help your patient understand there's no silver bullet. There's no cure for PCOS. You have to address what is dysfunctional in the entire syndrome and making sure that you're giving them tools that they can utilize to be able to have control over their body again.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.